Welcome to today's webinar, Quality Measurement and Peer Support, Meaningful Measures for Consumers and Payers. My name is Kelly Davis. I'm the Director of Peer Advocacy Supports and Services in MHA's National Office. I'm excited for you all to join us and hopefully have some discussion around quality measurement and peer support. Just some logistics before we get started. The webinar recording and slides will be available by the end of the week on MHA's website. And we'll also send them to all attendees and registrants in case folks have missed it, have to drop off early, or just want to share what they've heard today with some of the folks in your network. For audio, you can use your computer speakers. If you see the top of your computer, there is a phone icon. You can give the computer access to your mic and audio, or you can call in using your phone at the number listed at the top of the chat box. I'll also be monitoring the chat box throughout our webinar, and if you have any questions that you'd want us to address during our Q&A at the end, please feel free to leave those there. And a little bit about the presenters. So I'm Kelly Davis. I'm the Director of Peer Advocacy Supports and Services in MHA's National Office. I work on promoting the expansion of peer support throughout healthcare and some work in college mental health and young adult mental health. And I work on MHA's National Certified Peer Specialist Certification, the first National Advanced Peer Specialist Certification. And I'd like to announce my co-presenter, Nathaniel Counts. Nathaniel Counts is the Associate Vice President of Policy at Mental Health America. He works on innovative federal and state policy solutions for problems in behavioral health. In particular, he focuses on issues in incentive alignment and sustainable financing in behavioral health care, as well as issues in population health. Nathaniel is an expert member of the Forum on Promoting Children's Cognitive, Affective, and Behavioral Health at the National Academies of Science, Engineering, and Medicine, and he serves on the Board of Directors for the One Circle Foundation, CHAD, Children and Adults with ADD, and the Flawless Foundation. Nathaniel received his JD cum laude from Harvard Law School, where he was a Petrie Flom Center for Health Law Policy Student Fellow, and his BA in Biology from Johns Hopkins. His most recent publication was Promoting Mental Health and Well-Being in Public Health and Law Practice in the Journal of Law, Medicine, and Ethics. So just an overview on what we'll be talking about today in our webinar, Quality Measurement and Peer Support, Meaningful Measures for Consumers and Payers. So we'll start by discussing the current focuses of cost and quality improvement in healthcare broadly and in peer support specifically. We'll look at different measurement frameworks that match the lived experience of consumers with what we focus on in healthcare. And then finally, we'll discuss how we can tie improvements that matter to the individual to reimbursement. And just a reminder for folks that have questions throughout, feel free to put them in the chat box and we'll try to address all of those at the end of the webinar. And I will hand it over to Nathaniel.
Thanks so much, Kelly, and I'm excited to be speaking to you all today. So we can start with a little overview of what the history of measurement is, and quality measurement in particular. Because I assume there's always been, some kind of measurement in healthcare since the dawn of time, checking whether people's symptoms are getting better even on an informal basis. But for the longest time, we used to live in a world of fee-for-service payment where doctors, nurses, all kinds of providers did different procedures and got paid for each procedure they did. And there wasn't a lot of measurement. It was really, we had licensure and certification processes, and if you were a doctor in good standing or nurse in good standing or any kind of different provider, you were assumed to be giving quality care, and we didn't really measure very much. I think really with the greater accessibility of data over the past couple decades, there's been much more of a focus on measurement and value. Some very high-profile studies began to draw out that everyone in America wasn't receiving exactly the same quality of care, and in fact there was a lot of variation between providers, and maybe we ought to be measuring some of these things to make sure that everyone's getting the kind of care we expect. And then there also became a kind of accountability cycle where employers who are buying their employees' health insurance want to have the health insurance plans be accountable, and the health insurance plans who are paying for the provider services want the providers to be accountable, and the patients who are receiving the services want their payers and their purchasers and their providers to all be accountable. And so there's began the cycle of quality measurement and a shift towards paying for value over time. So we can go on to the next slide. So CMS gives a long and exciting definition of quality measurement that you can read. So that's from our Centers for Medicare and Medicaid Services. So they, guide all the quality measurement for Medicaid and Medicare, the two largest public payment programs. But I think for the purposes of everyone on the phone today, quality measurement is the formal processes by which we document some aspect of care. It can be a process, so did we do care planning with someone who just was diagnosed with a mental health condition, or did we screen them? It can be a structural kind of measure, like does this primary care have integrated behavioral health, or it can be an outcome. Did this person get better over time? And there is now hundreds and hundreds of these quality measures through all sorts of different processes that endorse them. To the extent some people have even called it the quality measurement industrial complex. But it's dense and confusing, but I think it ends up controlling a lot of healthcare, and so it's very worth learning about, and that's what we'll get into in this next slide. So why focus on quality measurement? It gives providers a chance to see what we're doing and what we're paying for and everything, and see what we're doing right. Are some of the things we're doing really working well, or are the things we're missing out on? And where we are demonstrating value, the third point, which is really, I think, going to be salient across this presentation, is getting paid more for what we are doing right. So if we can show that we are doing something of value, we can then prove it beyond just, assertions to the payer, and then get reimbursed more for something that really is effective. And then across the system, figure out ways to then reprioritize resources towards things that do seem to be having the biggest impact, and or towards providers who really are demonstrating value. And that's kind of the overall dream of this volume to value transformation we're seeing nationally. And so I've mentioned that there's hundreds of quality measures in all sorts of different programs. So the question arises, where are we in behavioral health? The answer is we are not as far as we might like to be. Even in meetings, sometimes when people are presenting on the quality measures in youth, we've seen confusion and outrage in some cases. And the issue is collecting true outcomes is really hard. It's really easy to create quality measures that are based on the kind of things that payers normally have to gather, like your diagnostic codes or the different procedures you build for. But the closer it gets to true outcomes, the more complicated it begins to get to collect. The provider has to take the time to administer the instrument. So if it's something like, you might be familiar with the PHQ-9, it can take more time, and they have to enter it in the system, and the system has to extract it and feed it on up. So where this leads us is we have these many different overlapping quality measurement systems. So there's one called the National Committee for Quality Assurance, which NCQA, which has this huge database of measures called the Healthcare Effectiveness Data Information Set, HEDIS. And so that was actually originally formed by employer groups who wanted a way to see and compare how different health insurers were doing in providing care for their employees. And since then it's expanded, and they also do quality measurement for not only commercial plans, but also for Medicare and Medicaid. And so you can look online on their website, you can see all the different HEDIS measures. And so you'll see there's like a whole set on depression, and one's on medication adherence, and I think we'll go into some of the more interesting ones in a moment. Then there's each state has its own Medicaid measures, and so for some of you that even are Medicaid providers, some of the measures you might end up collecting and reporting might be related to that. And more recently, there's a mandatory Medicaid core set that states have to report on related to behavioral health, so that's actually growing. And that's mostly for, at the state level, to see how states are doing with their Medicaid programs, and a lot of that then goes on to Medicaid managed care as well. And then finally, there's Medicare Advantage Star. Well, not finally, there's still maybe like 20 more measurement programs, but finally, for the purpose of the slide, Medicare Advantage Star ratings. So there's traditional Medicare, which is your normal fee for service, and then there's Medicare Advantage, which is administered by the different health insurers, and they have their own quality measurement and star rating system. So they get 1 to 5 stars based on how they're doing on these quality measures. And for all of these, it might seem like, well, who's really paying attention to this? It actually does have a really big impact on the way that insurers and different providers, all these different systems interact. And it is like sort of top of mind for all the entities in this ecosystem. So when you think about like, oh, what I'm doing adds value, for a lot of people, value ends up being framed around these quality measures, even whether they think it's right or wrong. It's sort of what's being collected and what's being measured, so it ends up being really meaningful for them. So the first one we'll touch on, which I think is just shocking. Every time we see it, it just blows our minds a little bit. So NCQA collects follow-up after inpatient psychiatric hospitalization. So you can see within 7 days post-discharge, does someone have a single outpatient visit they billed for? Or within 30 days, do they have a single outpatient visit? And so this is after like inpatient psychiatric hospitalization. You'll see the 7-day is as low as 32% and as high as 48% average across the different health plans. And then at 30 days, between 52% and 69%. And so these are people with incredibly high need. And you'll see, even at the best, the commercial HMO plans, around on average, about 30% of people aren't receiving outpatient services at follow-up. And so this is kind of one of those areas where quality measurement works well to motivate better performance where there's a lot of variations, but if everyone's sort of straggling around the middle, then it can be harder to get people to move ahead. But so this is something that insurers are interested in performing better on, and something to keep in mind. And then similar kind of statistics around follow-up after emergency department visit, and then for substance use. And then you'll see antidepressant medication adherence is really salient as well. This is partially because it's easier to capture using the different kinds of claims data they have available, so they can see, easily did this person repeatedly get their medication refilled. So it's an easy kind of measure to collect, and it can indicate something about the effectiveness of treatment, like were people given something that they wanted to adhere to. But also, for people, they can also raise some issues like, are people being adherent when it might not be the best course of treatment for them as well? And raises questions about, like, did people then receive the right care if they decided a better treatment would have been for them? So, and there's also, it's not nationally reported yet, but we're beginning to collect data on depression remission and response at 12 months. So over a 12-month period, how many people went from being depressed to not depressed, or from very depressed to less depressed using the PHQ-9, the Patient Health Questionnaire 9 scale. And we don't have the national level averages to report on that yet, but Minnesota's been collecting that data now for quite a number of years, and their average has hovered around like 9%. Which is not great. And so what all this says is that there's a lot of challenges in quality measurement at the moment, and a lot of motivation. We have opioid epidemic that is, sitting on top of all sorts of other addiction problems. This is the most salient of any number of substance use problems facing the country at the moment. And then growing rates of suicide now for decades, and acute increase in youth suicides in the past several years. And so we're not doing great at quality measurement, and this really matters, I think, to people. And these quality measures that we kind of went over begin to frame how people think about quality and mental health and substance use. So I can turn it back over to my colleague Kelly Davis to talk about the peer aspect now.
Thanks. So obviously we're not doing a great job given what we've seen, and want to tie in where exactly does peer support fit into all of this. So it's really at this point implicitly there's not much conversation around peers and quality measurement, specifically including peers, and often peers have focused on other measures than those that we just talked about. So peers are generally and the peer support programs and the peer support community is generally more interested in how people are doing broadly. So how are you doing in your life, in your well-being? Are you hopeful about your future? Are you connected with individuals in the community? And less on the clinical process measures that we're seeing so far. But still, peer support has been shown to impact the HEDIS measures that we talked about. So they're really great at improving engagement and follow-up. As we saw, there's huge gaps in getting people connected to anything after they show up in the emergency department, after they're leaving the hospital. And it also has been really helpful in reducing depression and substance misuse, and making sure people are engaged with their services in the ways that they want. So if medication is something that somebody chooses to take, they are able to explain and help people adhere to whatever treatment plan or treatment services that they want for themselves. So peer support works because it's more comprehensive and complete than the traditional focuses. As I just mentioned, we're really focused in peer support more on how do you live your life, and are you living a life of recovery and wellness in whatever ways that's defined for you. So questions about PHQ-9 score, about follow-up with your providers, and about medications are important, but they don't tell the whole story. And that's something that the peer community has been talking about for a long time. So the quality impact of peer support. So we do address traditional measures, but the scope of quality measurement is expanding, and we're looking at social factors that impact health and well-being from the payer and health plan world. They're beginning to realize that social factors are impacting these other chronic health conditions or healthcare service utilization. And they're also looking towards patient-reported outcomes that capture what's important to people. And I always like to note in these conversations that the peer support movement has anticipated much of what we're currently learning and how we're deciding to invest resources. So the peer movement has known that making sure people have healthy connections in their community is important, making sure people have access to work is important, housing and food security, all the things that we've really known and have been working on in supporting people in a more comprehensive way. We're beginning to examine and measure from the payer plan to improve the impacts that we've been, to improve the outcomes that we've been kind of traditionally narrowly focused on in terms of clinical improvement and functioning. And I'm going to turn it back over to Nathaniel to talk a little bit more specifically about, given what peers have known and what we're figuring out in broader well-being and public health, what are the things that we could change in how we measure and build and focus?
Yeah, and I hope all of this begins to point out a sort of interesting dichotomy where when you think about, like, you say, like, make a case, like peer support improves quality for mental health care in the United States. When you first say it improves quality, most people in the healthcare ecosystem's mind will go towards HEDIS measures, National Quality and Forum endorsed measures, that whole measure set. And the point there really is, like, peers do improve quality along those lines. It's often not what we have in mind when we think of quality. We think of improved quality of life and social functioning and all these things. But they do improve quality, and those things really matter. But there's two parts to it. So those current quality measures matter, and everyone is frustrated that the scores aren't improving as fast as they might have thought. There's all sorts of systemic issues and, motivating change at all these different levels and across the geography of the United States. And everyone wants to do better, and everyone needs help. There's also the second part about, and also everyone's frustrated with their current set of quality measures. When people go to sleep at night, they're not like, oh, thank God we increased medication adherence from 67% to 68%. They want to think, oh, we actually improved the lives of human beings across the United States. But the biggest barrier is the measures we have available don't always get at that, and everyone's looking to both improve quality as it is now and improve quality measurement to better get at what matters. And so CMS, for example, has a meaningful measurement initiative that's trying to focus on really getting measurement down to things that people care about and trying to, because people hate being measured on all sorts of things that don't really matter. And so that's really one of the current focuses as well. And so we wanted to bring up some of the interesting places where things are going, where they should be going, where peers have historically added value and already taking things and have for decades and decades, and dive into that a little bit. So the two parts we'll talk about are social determinants of health, which have been around for like 40 years but are now a hot topic in DC, and then patient-reported outcomes with a couple of really cool examples there too. So social determinants of health, most people have a sense that most of health happens outside of healthcare. You're in your doctor's office for 15 minutes, but your actual health is made up of some of the experiences both inside and outside, and most of your time was outside of that. And so Robert Johnson, for example, has this great little diagram to the right that kind of demonstrates some of the things they think are interesting related to social determinants of health. That's probably the exact amount that's made up of social determinants of health versus the more clinical determinants. I think it's like 80% outside of the clinic, 20% inside of the clinic is the rough estimate, something like that. And more so, as healthcare costs increase, as health outcomes don't improve, everyone is starting to talk more and more about social determinants of health. And then there's even growing interest in measuring it. So some of the things we can begin to think about measuring are rates of, there's a lot of initiatives related to peer support and diversion, post-incarceration, sort of reintegration in the community, all of these issues. And so rates of justice involvement, both initial contact and then repeated contact, can be legitimate quality measures related to healthcare, and I think are increasingly growing in interest. Food insecurity is a really big focus too. Like, do people have consistent access to nutritious foods? Housing security, do they have a safe place to sleep at night? And that includes, I think, both having a physical place, but then also the safety and stability of that place. Does it meet their needs? And then financial security is increasingly something that healthcare systems are actually screening for when people come in for their visits, and I think beginning to measure at a systems level. And some other examples are like a new pilot out of CMS focuses on aspects of like juvenile justice and out-of-home placement and child welfare. So I think there's increasing interest around it. The big issue is who's responsible for the actual outcomes. So there's a lot of interest around screening for food insecurity and financial security. Who and how and what it means to be held responsible, like a change over time measure for social determinants of health, is very up in the air. But I think to the extent more and more peer support is implemented nationally, people will get more comfortable with quality measurement around social determinants of health, because it won't just be your primary care provider being held accountable for your housing. It'll be, no, there's actually an entire continuum of care around it that makes supported housing, supported employment, the supports that people need, feasible and possible. And so this is, Kelly pulled some great articles and examples of how health plans are already beginning to move towards social determinants of health. So United Healthcare just launched a huge initiative around social determinants of health, and Kaiser Permanente. And increasingly it's going to be built into all the claims and administrative data that makes it easy to make quality measures, so that'll make a big difference. And more health centers are beginning to screen for the entire battery of social determinants. So all the data is going to be there, and eventually they're probably going to be increasingly turned into quality measures. This is such a clear area of value that peers can play. Another thing that's been coming up too is the first way that healthcare began to kind of address social determinants of health was just through screening and referral. So you screen for financial insecurity, you find a community-based organization or a government agency that's able to meet that need, and then refer. Initial research has been finding that just referral appears to be insufficient for people. Even though they understand and appreciate the resources that are available, the referral by itself for people facing, financial and housing insecurity doesn't necessarily make them better off, and might actually increase their level of stress. So peer support can play just an enormous role in addressing, in filling that gap and making sure people actually get the service and feel comfortable and confident in accessing things that meet their needs. And so we think peers will be just really important as healthcare moves towards this aspect of quality measurement.
Yeah, and just on that note, most people know, right, you can Google the things that will change your health, right? People know the things that they need and the things that they should be able to do, and it's important that we're sharing that information with them. But the key part of how peers tie into this is that they help address whatever specific barriers and help people kind of make a plan and support them emotionally in whatever ways that they can in navigating the new information they have access to, because we can see from almost all we know, we all have all this access to information, and the sharing of the information is important, but having a way to support people in taking that action is what's going to make the real difference in terms of short and long-term outcomes.
So that was social determinants of health. And so these are kind of two big strains of healthcare progress that we're looking at right now that are especially relevant to peer support. The second one is patient-reported outcomes. So patient-reported outcomes are actually just any outcome that's exactly what it sounds like, where a patient reports it. So they don't have to be person-centered or even meaningful. They could be anything that a person fills out on a form. But for our purposes and where things are heading is increasingly it's person-reported because only the individual knows if they're getting better in ways that actually matter to them. And so that's why it ends up being so salient. And so since the core peer support philosophy has been, finding out what does matter to individuals and then making sure they're actually making progress in those domains, the movement towards person-reported outcomes ends up being really important for peer support. And so right now, as I mentioned earlier, we have the PHQ-9 outcome measure. So as just an example, it's like if you scored positive at the beginning of the 12-month period and you score negative at the end of the 12-month period, that's how that quality measure works, and that is technically a patient-reported outcome because the person has to fill out the PHQ-9 form for depression. But I think there's increasing interest in moving just away from these symptom scales and towards more person-centered patient-reported outcomes as well. And that's really, I think, even though a lot of the studies involving peers demonstrate improvements in PHQ-9, I think that people can really shine in more person-centered ones as well. And I think from all the indications from CMS, from payers, from providers, it seems like where we'll end up is going to be a really strong focus on person-centered, person-reported outcomes. And so we're going to go into two really cool, promising ones that honestly I talk about every chance I get, and everyone around here is pretty excited about. Goal attainment scaling and the Promis Measure set. So we'll start with goal attainment scaling, goal setting. So goal setting generally is just a common part of peer support. And so I can turn it over for Kelly if she wants to talk a little bit about the figure 2.
Yeah, so one of the key ideas that we talk about in peer support that's related to goal setting is, it's not just people getting support moving away from their challenges, but the real difference is helping people move towards what they want in life. And the image or the graph on this slide is from a pilot that we did at MHA with Kaiser Permanente in Northern California and one of our affiliates, MHA of Northern California, where we worked with folks in an outpatient setting who were Medicare and Medicaid eligible, and helping them with their kind of comprehensive needs. So the people involved were folks with a history of mental health diagnoses, but also an additional chronic health condition. And as you can see, we really emphasize the importance of working with a peer, not only for support, but for meeting goals related to all of those different categories, like mental health, but also financial goals, housing, personal safety, isolation, and community involvement, and kind of the things that we were just talking about with social determinants of health. And, it's not just great that we did this for people because it improved their lives, which is really what we want, but also from the payer perspective, just with 2 full-time peer specialist employees working with this group of people in this setting as part of their healthcare teams, we were able to save about $1 million over the course of the year. So really focusing on the comprehensive wants and needs of people makes sense for those of us who care about people and their lives, but also makes a lot of financial sense as well.
And so there's actually a specific measurement concept related to goal setting called goal attainment scaling. And so the basic idea of it is you meet with your provider or whoever, peer, someone meets with you, and you pick a SMART goal. And I cannot for the life of me remember what SMART stands for, but it's, the idea that it's like concrete and specific and specific, measurable, achievable. So anyone who's ever been in a meeting remembers what SMART goals are. So you pick a goal that's attainable probably within, let's just pick an interval, 3 months or 6 months. And then you give some goals with their importance and difficulty. And then, so you set your goal, then you check back in at the end of the interval, and then you see how it went. Did you do better than expected, somewhat better, worse? And so it's pretty exciting. It's totally open-ended. People can pick whatever matters to them, and it shows concrete progress over time in a way that's very resonant with the way the peer support works, with the way recovery works. Sorry, Kelly, it's something to.
Yeah, and I think too it speaks to a lot of the complexities of that people in the disability community identify as having. So, for example, I'm a person with lived experience, and my sense of what it looks like to achieve a specific goal would likely vary from somebody else with the same diagnosis. My goal isn't necessarily to change my PHQ-9 score, but it also kind of includes the importance of all of the other ways that I, as an individual person, might care about that might not be something that you can kind of look at more broadly across the community, because we are all different and have different starting points and different wants and different places where we need to end up. So having a measure set up this way really gives individuals the opportunity to select the things that are most important in their lives and help to financially support the ability for them to do that in the ways that makes most sense for them, which is really in line with what we talk about with voice and choice and peer support.
And my sense is most people in healthcare think the end dream of measurement should look something like this. Everybody has some sense, if you've ever had any health condition, that everyone's goals are a little bit different, and better means something different for everyone. And we should in some way capture that in quality measurement. How to turn that into something that you can use to compare health plans, compare providers in ways that are fair across comparison units, I think is the major battleground. And not that it's not possible, it just requires both technical focus and then advocacy. People have to be encouraged to spend the sustained time and attention to figure out how this could work, rather than just continuously picking off easier targets in the meantime. So we wanted to kind of lay this out for you before we go on to the Promis Measures. So the Promis Measures, it's funded by the National Institutes for Health at many millions of dollars. And it stands for the Patient-Reported Outcome Measurement Information System. And the original goal of it actually was to standardize, I think, outcomes measurement in neurology research, because people were trying to measure lots of different aspects of functioning, but using all different measures, and you couldn't really compare studies. So they created this originally for neurology, and then realized, oh my God, this actually is helpful for everyone. And so over time, it expanded to measure all sorts of aspects of physical, mental, and social well-being. And it uses a lot of the fanciest quality measurement techniques. So it's all computerized, adaptive tested, so it knows if it's picking the fastest possible set of questions for you to get to an answer. It has all sorts of really good psychometrics. The issue is it was originally designed for research, so it's not really being used in clinical care almost at all today. But a lot of people are pretty interested in it and trying to figure out how to use Promis in clinical quality measurement. And even if Promis doesn't end up being used in clinical quality measurement, really the point here is something similar will probably be used. And having this out there is a pretty, oftentimes we run into things where someone's like, whoa, well, social isolation, there's no valid way to measure that, or meaningfulness in life, and it's like, well, have you seen Promis? Here's a million studies on that topic, and then everyone it kind of changes the conversation. So they have, maybe even thousands, but at least hundreds of items measuring all sorts of things. But so you can put together a series of them and create a scale on social isolation. And we pulled some of the questions on this so you can kind of see what that looks like. And so when you think about what peer support does, this is clearly in the lane of peer support. And social isolation is becoming a really big focus of healthcare too. There's studies showing that social isolation is worse for you than smoking, for example, and a huge risk factor for all sorts of really high cost problems. So a lot of people are getting really into it. You can look at how interesting some of the measures get around, even the appeal of substance use. So it's not just a series of constructs like, did you use substances? Are you no longer using substances? You can get at every aspect of substance use and addiction and mental health and cognition that could matter to people to really capture what matters most for change over time. And then when you think about recovery in particular and what does real recovery look like and how do you measure it, there's always a kind of question how do you measure recovery? And especially a lot of the instruments for measuring recovery came out of community mental health, and so aren't broadly applicable across. You can't a lot of the recovery scales developed in community mental health wouldn't work for someone who just was diagnosed with moderate depression, for example. They're meant for people who have kind of gone through multiple systems. And so while they contain some of these scales, there's a kind of need for scales that kind of capture these aspects for everyone in the population. And so you can measure meaning and purpose with really good psychometrics in ways that absolutely matter to people in recovery. Here's one for emotional support when you're thinking about other aspects of recovery. And so that's the Promis measure set. If ever you're worried something can't be measured, probably it can be measured through Promis to some extent. And you can look it up. I think it's healthmeasures.net is the website. We have no financial relationship with Promis. We're just their biggest fans a lot of the time. Here, I'll turn it over to Kelly.
Yeah, and just to speak a little bit more to the importance of some of the things we just looked at, they are really in line with what we've known has been most powerful for people who are struggling with emotional distress from the consumer peer movement perspective. So, for example, Nathaniel talked about the growing problem of social isolation and how folks are saying, social isolation is the new smoking because of the impact it has on your health. And what we're seeing as social support as being one of the biggest predictors of lifelong well-being. And just for an example of how peers fit into that context and how it really in the real world has serious impacts. At MHA, we have a program called Social Self-Directed Care where we worked with, in the initial pilot, women who were diagnosed with schizoaffective disorder and had a high number of hospitalizations within the previous year. And they worked with recovery coaches using some life coaching, peer support, and some of the principles of psychiatric rehabilitation to help folks make community connections and find things that were meaningful for them and find relationships that were meaningful to them that weren't tied to their diagnosis, that weren't tied to the time that they were spending in community mental health centers. And what we found was over the course of the year in the pilot, the rate of hospitalizations among a group of women who had a high number was reduced by 90% just by giving folks support in building social relationships in the community. So I just want to tie in again that it's not just things that we care about and think are important, but there's really increasing evidence that the broader goals of what we think of when we think about healthcare and helping people is letting people live the lives that they want in whatever ways that are important to them. And looking at measurement from this perspective really ties into what we focus on as peers, but also what the evidence is increasingly supporting.
And so we wanted to end on a slide of what are the stakes in quality measurement? Why would we have an entire webinar on peer support and quality measurement when it's often a topic that's left only to full-time quality measurement folks and not something that everyone engages in. So the first is there's a quote often thrown around at meetings called "What gets measured gets treasured." And so while impacts on things that aren't measured are definitely important, and everyone would agree, impacts on things that do get measured show up on reports and spreadsheets and guiding policy documents, and really grab people's attention. So to the extent peer support has an impact on what's being measured today, that really matters. And to the extent measurement evolves to demonstrate that value, then that matters all the more. And it's not just that what gets measured gets treasured. It's also there's a simultaneous shift towards actually paying based on that measurement. So it's slow right now, but hopefully it'll be increasing, that the better outcomes you get, the more money you'll receive. And I think that'll increase over time as the measurement systems get better and we figure out how to allocate incentives effectively. But eventually it's not just like, oh, it's nice that I'm doing a little bit better than my peers, peers in the other sense, competitors. But it'll actually, affect your bottom line. So if you're able to demonstrate impact on what's being measured, it is valuable to the person you're working with, but also I think could help financially sustain peer support. If it's able to increase that rate of follow-up after initial hospitalization, and that's one of the things being paid based on, which is unfortunately is not, I think it's included in some of the measure sets today, and it's probably part of a composite that ends up determining payment for at least some programs, but I don't think it's one of the most salient ones. But if that got ratcheted up and it ended up being really valuable, that people get that follow-up after 7 or 30 days, and people are really struggling with how to increase those numbers, if peers can come in and increase that to an extent that way more than covers the cost of the peer support specialist, then you have just a sustainable business case for the integration of peers. And I think you're going to be seeing that more and more and more. And that's like one of the big cases we've been making here at Mental Health America. And I think the other point which Kelly made, and she I think can expound on a little bit more, is peers not only demonstrate value in the ways today, but they basically anticipated future trends and current trends and where we're going to end up. Like, they're adding the kind of value that everyone's hoping to capture. So the closer we get towards that, the greater that sense of value produced by peers will become. But, and this is really the important thing we want to end on, is we are like, quality measurement's been around, I guess, since anyone asked someone twice how they were doing. But we are still like early in the process of like systematic quality measurement in any way that makes any kind of policy sense. And like, I guess we're on this track towards better measures, but it needs all the help it can get. It requires constant advocacy to demonstrate like why better measures would be helpful, to demonstrate that better measures are possible or feasible or worth us spending the time and energy to develop when there's so many other competing demands for everyone's time, and that these things are valuable and should be tied to payments, and that they're measurable and that we can have these impacts. Because oftentimes, people may not even be sure, like, oh, can you really impact social isolation or social functioning through intervention? And peers, I think, have, just decades and decades of proof that these things are possible, and therefore worth measuring because they matter so much to individuals. So that's what we wanted to drive home about the stakes of this, and then I'll turn it over to Kelly to see if she has final thoughts.
I think Nathaniel did an awesome job summarizing why we think this is important, where we think this is going, and the importance of, we're focusing on this a lot at MHA in our policy work and in our work more broadly related to peers. So we're always happy to work with folks to explore these ideas further. I've included on our contact us page, Nathaniel is available by email. I am available as well. It's just our first initial last name at mentalhealthamerica.net. And thank you all so much for joining us. We left about 15 minutes at the end for questions. For folks who have them, feel free to please type them in the chat box, and I'll go over some of the things that were mentioned so far. So Angela kindly pointed out what SMART goals stand for. For Nathaniel, specific, measurable, attainable, relevant, and time-based. Thank you, Angela, for your help.
Thank you.
The next comment, the next question we had was, what was the name of the pilot that we did with peers on social inclusion and isolation? So that pilot was called Social Self-Directed Care. The initial pilot was done with individuals working one-on-one with the peer specialist, but we've actually updated the program to be run on a group basis in a group format to reduce some of the costs for folks who want to offer the program, and we do provide technical assistance for different organizations who are interested in bringing the program to their communities. So please feel free to reach out to me directly if you are interested in learning more about that. You can also find out more about the SFDC program. We have a ton of resources, a bunch of webinars that explain kind of where we came from, what we did, and further explain the impact at the Center for Peer Support that we run through MHA. It's just centerforpeersupport.org. And let's see, next question. Caroline said, several of our medical services use Promis clinically at the University of Rochester Medical Center.
Oh, Caroline, if you have the free time then to submit that as a quality measure to the National Quality Forum, we would be forever grateful.
Can you expand?
So in order for something to go from something that someone does to something we all now have to do or should do, there's a body called the National Quality Forum that's actually funded by the government that goes through a process of endorsing measures, and you can submit measures, and then they go through like kind of peer review processes and voting and all this, but it is a long and challenging road, not for the faint of heart, and that's been one of the barriers, I think, to getting Promis. It's sort of like a hot potato. Like everybody wants it to happen, but no one wants to be the one to hold on to it.
Awesome. So next question from Christina. I currently use the Recovery Capital Scale to measure. Are there any other measuring tools out there being used? So there's a lot of different tools that people, especially in the peer world, are using to measure what they think is important and ways that they're building or they're organizing their programs to achieve specific outcomes. But I'll let Nathaniel speak a little bit about the relationship between something like a recovery capital scale to quality measure.
Yeah, and so, and like Kelly said, there's a bunch of, I think there's like a recovery assessment scale, and I'm not sure, I think there's a bunch of, I've reviewed some, I can't remember all of them offhand, sorry, but the biggest question is just going from something that's like meaningful internally, so trying to figure out for your own treatment planning and using a scale repeatedly, and then at like a program evaluation level, like how do we as a peer support program or a, a community mental health center feel about the services we're doing through these kind of evaluation techniques. And going from that to like the level of validity that you can actually compare providers is a long, as you just mentioned, a long journey. And so trying to figure out what do we want to put that much effort into for recovery has been, I think, one of the biggest challenges. We want something to get over the fence for recovery, but figuring out exactly what it is has been the struggle.
Thanks. And the next comment is from Adam, and Adam said, this is great stuff. I've been trying to configure our new data system to measure self-reported outcomes rather than simply a record of services provided.
And increasingly, just for those who use the different like electronic medical record services like Epic and all those, a lot of the like Promis is already integrated into all of them, and a lot of these are. It's just, and even for a lot of the like provider registries, a lot of them use a lot of these scales. It's just been getting people to use them for quality measurements has been one of the biggest challenges. So we hope everything goes well with your clinical data systems integration. We know it's a struggle.
Anthony asks, are you going to email out the PowerPoint slides? Yes, the PowerPoint slides and the recording of today's webinar will be available on the MHA's website, but will also be sent directly to everybody who registered for the webinar today for you to view yourself, but hopefully share with some of the folks that you work with as well. Angela said, I think for one of the other measures, Temple University Community Participation Measure, and then Kevin added The Temple University Collaborative on Community Inclusion is engaged in research and knowledge development activities that are translated into practical information to support full and meaningful community participation of individuals with mental illnesses, and also linked their website, which is this tucollaborative.org. And looks like we don't have any more questions. I'll leave another few minutes for folks to add anything that they want to ask. I don't know if, Nathan, you had any other closing thoughts besides what you've already discussed.
Yeah, I mean, it's kind of interesting to go to, I think it's qualityforum.org. That's the National Quality Forum's website, and they have a Find Measures tab, and you can kind of click around and sort based on mental health or person-reported outcomes or all these different things, and get a sense of what, and you can see like what programs they're used in. So if they're used in CMS for Medicaid or Medicare Advantage star ratings or whatever, kind of get a sense of what it is people think about. Because we really, when people are going in and pitching the hot new healthcare product from their venture capital-backed firm, a lot of them are both showing like, here's quality of life kind of things that people really care about, those kind of improvements, but they're also really hammering on improvements in these like narrow quality measures. And so we wanted to equip people here with the same kind of lingo that the hot VC startups are using too. So it's definitely worth checking it out, and hope this is really helpful to everyone on the call.
Awesome. So it doesn't look like we have any more questions. Nathaniel and I will hang out for a little bit longer just in case folks have anything that they wanted to chat about. Otherwise, you can reach both of us or either of us via email at the emails listed. And we thank you all so much for your participation today, for the questions that you asked. And again, the webinar recording and slides will be available via email and also through MHA's website. Thank you all, and hope everybody has an awesome rest of your day. Looks like Joshua said, could an abbreviated system be used validly?
Like a short system of quality measurement, you mean? I think a lot of things could be valid if people take the time to validate them, and that's always kind of the issue is if it takes like, I mean, honestly, like literally millions of dollars and years to get from even an already well-developed scale to a valid quality measure. So you have to show, like, make sure that it works across different populations and provider types and settings, and it won't. And it sounds like a huge pain for no reason, but it actually is, make sure that the measure you're proposing doesn't just disadvantage a group of people and create perverse incentives in healthcare. So there is like good reason that it's so complicated, but the other half of it is that not everything we might want to see gets through. So I think you can have, a huge array of things are possible. It's just the advocacy to make sure that someone gets over the finish line.
Awesome. All right. Thanks, everyone.